Welcome to this explainer. Today, we're diving into the fascinating, highly orchestrated biological road trip a drug takes the second it enters your system. It's not magic that makes a medication work. It's a brutal, perfectly calculated gauntlet of physiological events. Seriously, every time you take a medication, do you ever stop and wonder how clinicians calculate the exact therapeutic window? How does a tiny molecule survive your stomach acid, hit its exact target, and then just exit your system right on cue? Well, to answer that, we'll follow this journey chronologically. First up, what your body does. Then, getting the drug in. Next, the 4 phases of ADME: absorption, distribution, metabolism, and elimination. And finally, how we use all this data to perfect the dosage regimen. All right, section 1, what your body does. This is the foundation of drug interaction. To really get this, we need to separate 2 fundamentally different concepts about how humans and medicine interact. You've probably heard of pharmacodynamics. That's what the drug does to you, like lowering your blood pressure or stopping a cough. But today, we're focusing purely on pharmacokinetics. That's the incredible set of mechanisms your body uses to handle the drug. It dictates when the medicine starts working, how intense the effect will be, and how long it sticks around before your body gets rid of it. Moving to section 2, getting in, or drug administration. This is the starting line of the journey. And what's fascinating here is how this starting point dictates absolutely everything that follows. Take swallowing a pill by mouth. It's super common and convenient, right? But it's actually perilous for the drug because it has to survive a literal acid bath in your stomach and navigate complex absorption pathways. On the flip side, intravenous or IV administration skips the line entirely. It delivers maximum control and a super rapid effect. But the catch is that it's completely irreversible once injected. You can't just pump a stomach to get it back. And that brilliantly illustrates why IV administration has an absolute bioavailability of 100%. Because the drug is placed directly into the systemic circulation, literally none of it is lost to the digestive system or the liver's initial filtering. If a doctor wants complete certainty about exactly how much drug is in your blood, this is the gold standard. Okay, section 3, ADME. Absorption and distribution. We're navigating the biological highways now. Let's move to the core framework of our journey and see how this builds into the famous medical acronym ADME. ADME stands for absorption, distribution, metabolism, and elimination. These are the 4 critical checkpoints a drug must pass through in your body. Basically, every single pharmacokinetic calculation your doctor makes is based on these 4 pillars. Let's break down those first 2. During the absorption phase, a drug has to fight through various barriers to actually get into your bloodstream. It's definitely not a free ride. A drug has to move across cell membranes, which depends heavily on its chemical makeup, like its pH and lipid solubility. It's also wildly affected by blood flow and total surface area, which is why your intestines, with their massive surface area, absorb way more than your stomach. There's even a protein called P-glycoprotein that acts like a cellular bouncer, aggressively pumping drugs right back out of the cells. Once it's absorbed, we enter the distribution phase. The blood carries the drug all throughout your body. Organs with high blood flow, like your heart and liver, get the drug super quickly. But your brain has continuous capillary structures with tight junctions. This is the blood-brain barrier, and it acts like the ultimate VIP bouncer. It strictly protects your central nervous system, only letting specific, highly lipid-soluble drugs inside while keeping ionized or polar drugs out on the curb. That brings us to section 4. ADME, metabolism, and elimination, processing and exiting the system. The crucial point here is that once the drug has finally reached its destination and done its job, your body doesn't want it staying there forever. It immediately begins trying to alter it and kick it out. You can think of your liver as a super strict customs border. When you take a drug orally, it gets absorbed through your GI tract and routed straight to the liver through the portal circulation before it can reach the rest of your body. This is known as first-pass metabolism. If a drug is heavily metabolized during this first pass, very little active medicine actually reaches your general circulation. This is exactly why certain drugs, like nitroglycerin for chest pain, are taken under the tongue instead of swallowed. You're bypassing that liver customs border entirely. So how does the liver actually process all these drugs? Well, it achieves this chemical processing primarily using a huge superfamily of enzymes called the cytochrome P450 system. That massive 36% chunk you see, that belongs to the CYP3A4 and 5 family. This single group of enzymes handles over a third of all drug biotransformation, chemically modifying the drugs into water-soluble forms so they can be easily flushed out of you. But here's the thing, this enzyme system is highly sensitive, which leads us to the real danger of drug interactions. Some substances are inducers, like the herbal supplement St. John's wort, which basically force the liver to produce more enzymes, breaking down your medications way too fast and making them useless. On the flip side, we have inhibitors. This is exactly why your doctor warns you not to drink grapefruit juice with certain medications. Grapefruit juice actually inhibits those CYP enzymes, stopping the breakdown process and causing the drug to dangerously build up to toxic levels in your system. Finally, we reach the elimination phase. Thanks to the liver, the drug is now largely a water-soluble, inactive metabolite. It gets sent off to the kidneys to be filtered out of the blood through glomerular filtration and ultimately excreted from the body via urine. Now, if a drug is still too lipid-soluble, it might actually get reabsorbed right back into the bloodstream by the kidneys, which just goes to show why that liver metabolism step is absolutely vital. All right, Section 5, Perfecting the Dosage Regimen. How doctors use AMDE to prescribe. Now that we deeply understand the biological journey, let's look at how clinicians actually use these pharmacokinetic principles as tools to solve the ultimate puzzle, getting your dosage exactly right. When treating an ongoing condition, doctors aim for what's called a steady-state concentration in your blood. Think of it like filling a leaky bucket. You want to pour water in at the exact same speed that water is pouring out of the hole in the bottom. If you pour too fast, the bucket overflows. That's drug toxicity. Pour too slow, and the bucket empties. That's losing the therapeutic effect. Steady state literally means the rate going in perfectly matches the rate going out. But how long does it actually take to get the bucket perfectly filled? We calculate this using a drug's half-life, the time it takes for half the drug to be eliminated. By timing doses based on a drug's half-life, we can rely on a pretty amazing mathematical certainty. It consistently takes exactly 4 to 5 half-lives for the drug to accumulate and hit that perfect steady state in your blood, regardless of the specific infusion rate. And this brings us to the two main types of doses. For standard, day-to-day therapies, doctors use maintenance doses just to keep you at that steady state. But what if a patient comes in with a severe infection or a life-threatening heart arrhythmia? They cannot afford to wait 4 or 5 half-lives for the medicine to fully kick in. In those serious emergencies, doctors will use a massive loading dose up front to instantly fill the bucket, bypassing that waiting period altogether, and then follow it up with standard maintenance doses. Now, keep in mind, all of these calculations are initially based on a hypothetical average patient, but in real clinical practice, the average patient is a total myth. Every single individual has a different volume of distribution and varying rates of clearance. Doctors must continuously adjust the math, customizing the dosage to ensure the drug stays within a very specific, safe therapeutic window for that specific person. This customization becomes absolutely critical when things go wrong in the body. If a patient has heart failure, renal disease, or hepatic cirrhosis, their liver or kidneys are heavily compromised. When that happens, the drug's half-life shoots way up because the body just can't clear it efficiently. To prevent a dangerous toxic buildup, the doctor is forced to prescribe lower doses or tell the patient to take the pill less frequently. Even slight genetic variations in those liver enzymes we talked about earlier can force a complete recalculation of the entire dosage. Understanding pharmacokinetics completely changes how we view a simple pill, doesn't it? It's not just a quick fix. It's the launch of a precisely calculated biological road trip through the checkpoints of your own body. So the next time you look at a prescription bottle in your bathroom cabinet, ask yourself, do you truly know the absolute gauntlet that molecule is about to run? Thank you so much for exploring the science of ADME with me in this explainer.